Uh, I will be moderator for the next few hours in this webinar. As we know that the majority of the critical ill patients with COVID-19 have comorbidity. That's why the patient come to the ICU and more susceptible to be even more severe. The patient may need intubation and may need mechanical ventilation. As we know that intubation procedure is high risk procedure, and mechanical ventilation too lead to many complications like VIP. And today we will discuss many aspects about that, airway management and mechanical ventilation. Let me introduce our agenda today. We start with opening remarks with Chairman of Patien, and then go to the opening remarks by Medical Smith, and then we have 5 speakers. The first topic from infection prevention control from Dr. Titi Sundari from Indonesia. And the second topic is airway and critical management from Dr. Hoxon from Philippines. And the third topic, PAP management for COVID-19 patient from Dr. Raventin from Malaysia. And the fourth topic is early experience from ICU unit in Singapore by Dr. Deborah from Singapore. And the last topic is preparing for COVID-19, early experience from ICU unit in Indonesia by Dr. Rita from Indonesia. And end of the presentation, we have Q&A answer session. So it's about 30 minutes. It's not long time. We have to fix the time so we can make interaction. Let me introduce that this webinar has a pre-test. Maybe the participant can see in the below the screen. The pre-test can complete in the webinar session, and then after the webinar we have post-test, because you know this webinar has a CME point, so all the participants completely following this webinar and can answer more than enough the question. So our prom committee will give certificates. This about 3 weeks after this meeting. The certificate will be sent by email by prom committee. Okay, let's start from opening remarks from Perdatin. Prof. Safri Kamsul Arif. He's the chairman of Perdatin. Please present your speech.
Thank you, Mr. Chairman, Dr. Faisal. Assalamualaikum warahmatullahi wabarakatuh. Good morning, everyone, and welcome to today's webinar about airway management and also topic about the ventilator-associated pneumonia COVID-19 in ICU patient. I hope all of you, our colleagues, and your family remain well during this difficult period. I am Shafri, and it's my privilege and pleasure to be able to make an opening speech to welcome you here today. As the President of Indonesian Society of Anesthesiologists and Intensive Therapy, I would like to appreciate our speakers and participants that have participated in this virtual or Zoom meeting. Our speakers are all the experts on their field. There are 5 speakers today. First, Dr. Titi Sundari from Indonesia will talk about infection prevention and control for COVID-19 in ICU setting. Dr. Ron Jackson from Philippines with the topic airway and critical care management for COVID-19 patient. And Dr. Raventiran Russia from Malaysia, ventilator acute pneumonia management for COVID-19 patient. Dr. Deborah Ko Xian Lee from Singapore, preparing for COVID-19 early experience from an intensive care unit in Singapore. And the last is Dr. Dita Adityaningsi from Indonesia, preparing for COVID-19 early experience from an intensive care unit in Indonesia. I'm pleased to say that the topic of this meeting is very interesting and implicative, and it's really timely as we start completing about how do we perform airway management for COVID-19 as well as managing ventilator-associated pneumonia in our hospitals. COVID-19 infection have recently emerged at the hot topic in every country. Starting from March 11, the WHO has established COVID-19 as a pandemic. This condition is certainly cannot be underestimated. It's a reckon and that COVID-19 pandemic will take a longer time to resolve than expected, particularly in Indonesia. Even though the majority of COVID-19 pandemic patient is asymptomatic, around 5% of the patient will experience severe symptoms and become a critical ill patient that needs an intensive care. As the symptom mainly revolving around the airway management has become one of the vital components in managing COVID-19 patient. Insufficient airway management may trigger hypoxemia that leads to multiple organ dysfunction, and the majority of COVID-19 patients in ICU require mechanical ventilation for prolonged duration. And with now we know that mortality is so high. Combined with the cytokine storm, which impair the patient immune system, this will increase the risk for ventilator-associated pneumonia, further deteriorating the patient's outcome. As we all know, anesthesiologists held an important role in ICU, especially in airway management and treating ventilator-associated pneumonia. COVID-19 infection certainly provide a new challenge as we interact with patients directly. Not to mention the lack of PPE for aerosol generating procedure is in some hospitals. Therefore, these procedures are clearly high risk for COVID-19 patients. Knowing the step for infection control and prevention is clearly important in terms of protecting ourselves, our team, and also the other teams that are involved with us in the ICU until achieve the normal condition back. Those are the topics for today's webinar. I look forward to all the speakers and their contribution today. I hope this meeting will provide benefit to every clinician out there, especially who treated ICU COVID-19 patients on a daily basis. In order to optimize patient care as well as taking care ourselves, I also hope that all of us stay safe and strong during this difficult time. again, thanks to this Smith Medical for your supporting this webinar. And before I hand over to the moderator, Mr. Chairman, I want to say once more, welcome to this meeting for all participants. I wish to express my gratitude to see this many enthusiastic clinicians regarding this webinar topic. Thank you very much.
Thank you very much for Sapri opening this webinar. Now we are going to second speech from Director of Asia Pacific Distributor of Asia, Mr. Dipas, please.
Thank you. Thank you, Dr. Faisal. Thank you, Dr. Saifri. It is our privilege to partner with IDI and Patien for this very unique event. I would just like to give a short introduction about Smiths in 1 minute. Smiths Medical is a leading global manufacturer of specialty devices and provide life-saving solutions for hospitals, emergency care, and home care. And we are very passionate in supporting healthcare professionals to enhance patient outcomes and help save lives. During this tough COVID times, our company has stepped up efforts in battling the crisis. We have done several donations, supplied products like ventilators, pumps, catheters, and partnered with societies for unique events like this webinar. I think we are present in anesthesia and critical care space, and airway management particularly is a very important topic for us, and we are very glad to partner this event. And lastly, I would like to thank our distribution partners, IDS. They have been instrumental in helping us set up this event and connect with all the key stakeholders. So once again, thank you, Dr. Saifri. Thank you, Dr. Faisal, and all the speakers from different countries for making this event webinar very successful. Thank you a lot. Over to you, Dr. Faisal.
Okay, thank you, Mr. Dipas. Now we are going to the our webinar. We want to go into the first topic, infection and prevention control for COVID-19 in ICU setting, by Dr. Titi Sundari. She is the consultant pulmonologist, chairperson of Infection Prevention and Control Committee of Professor Dr. Sulanti Suroso Infection Center Hospital, Indonesia. Dr. Titi Sundari, you may start your presentation.
Good morning. Thank you, Dr. Faisal. Good morning, everyone. First of all, I would like to thank Smith Medical for this opportunity to join this morning. My presentation is about infection prevention and control for COVID-19 in ICU setting.
Please, you make it a slideshow, please. Okay.
This is my hospital where I work. Sulianti Saroso Hospital is a national referral for emerging infection like MERS-CoV, avian influenza, and also like swine flu. And now the has bundled in ICU. Last December, there is a novel coronavirus that has emerged and caused unusual viral pneumonia in Wuhan, China. This developed very rapidly until as a global health emergency, as WHO stated. Update now, in June 5th, there is more than 6.5 million confirmed cases and 6% died because of this. In Indonesia, only 2 provinces from 34 provinces that still free from this COVID-19. From 29,000 confirmed cases, there are mortality rate about 6%. Why infection prevention control is important? We know that 9 until 10% reported cases in Wuhan or Italia happens among the healthcare worker. All the therapy like Aluvia, Remdesivir, hydroxyquinolone, interferon still in clinical trial. So we have not any data whether of this therapy that's more effective than others. Neither do the the vaccination. More than 90 vaccinations are being developed, but and some of them has been injected to volunteer and also animal, but maybe we still need time to wait about the efficacy. So because there is no specific therapy, no vaccination, and the treatment is still symptomatic, the transmission is human to human and risk for healthcare worker, infection prevention control is essential to protect both patient and healthcare worker. COVID-19 are risk. COVID-19 are risk to develop respiratory failure and might require admission to clinical care unit. Various invasive procedures will be performed to them, which could be potential sources of virus transmission of healthcare worker. Careful execution of infection control is necessary to prevent transmission to other patients and healthcare worker. The transmission mode until now is still droplet and contact. Transmission happen while exposure to patient with COVID-19 via respiratory droplet that produced while speaking, coughing, and sneezing. Droplet could land in the mouth, nose, or eye people nearby and inhaled into the lung. Transmission could also occur through contact with contaminated surface, followed by self-delivery to eyes, nose, and mouth. Although it's currently unclear if COVID-19 is airborne, the risk of transmission during aerosol-generating procedure in ICU, like bronchoscopy, intubation, mechanical ventilation, suctioning, is there. So the infection prevention control strategy, the one is triage, early detection and source control. Second, applying standard and transmission precaution. And the third is implementing administrative control and environment control. Triage in early detection principally is separate COVID and non-COVID patient. So the staff should be training to have high clinical suspicion for this. Standard precaution, there is 11 elements that have to apply to all the patients in a hospital, include hand hygiene, personal protective equipment, environment cleaning, wash and linen management, healthcare worker protection, patient placement, and the other. For COVID-19, there is contact precaution and droplet precaution that added to this standard precaution. Airborne precaution also added to for to aerosol generating procedure. Implementing administrative and environment control, provision adequate training, ensure adequate patient and healthcare worker ratio. In ICU, in my ICU, the ratio is 1:1 or 2:1. And establishing surveillance among healthcare workers for acute respiratory infection, and also monitoring compliance. For environment, apply adequate ventilation, spatial separation more than at least 2 meters apart. Cleaning and disinfection procedure also manage laundry, food, utensil, and medical waste. Hand hygiene is the main pillar for infection control. Previously, there are 5 moments. There are 5 moments with two before and 3 after. Before touching patient, before aseptic procedure, after body fluid exposure, after touching patient, and after touching patient surrounding. But for this pandemic, we have encouraged our staff to do that more and more hand washing or hand rub, especially after taking off PPE, taking off glove or contact with surrounding like the button of lift, like rail knob, like handle of the door, etc. Personal protective equipment is used as indicated. It means that not everyone will use respirator, not everyone will use visor. But since in the ICU, there is risk of aerosol generating procedure, so the standard for PPE in the ICU is gloves, food-resistant long-sleeve gown or coverall, fit-tested respirator, N95 or FFP2 or 3, eye protection. We have to choose the eye protection that comfort for us, because for many activities in ICU, it's very challenging if we use the foggy Google. Also disposable cap, boot, and other. We have to prepare new set PPE for different patients. Donning and doffing PPE is crucial to prevent self-contamination. It has been supervised by IPCN. Doff or take off safely within a designated area like anteroom with equipment and environment enforced, because we know toilet and anteroom is the place that very much many microbacteria in them. And also our policy, everyone who in my hospital, everyone who enter isolation had to take a shower before leaving the ward. The outer surface of PPE is the most contaminated, so we have to pay attention about remove the PPE. And also always perform hand hygiene every step we take off the PPE. Then discharge the used PPE in the medical waste. And N95 respirator mask, there is so many types in outside. But for the surgery, the type of 1860 and 1870, which is fluid resistant, are recommended. Don't forget to press the part in the nose to adjust the contour of the face, and doing seal check, either positive or negative seal check. Now, sometimes we are lack of N95 respirator, PFPR, and also full face or half face mask as alternative can be used. In this pandemic, sometimes it's hard to get N95 respirator. The healthcare worker tend to wear the only masks that are available in the hospital without fitting process. Unfitted mask will consequently will give risk transmission, infection transmission because of the leak and gap between the cheek and the face. Qualitative fit test is subjective, sometimes depend on the sensory of taste of each person, from saccharine or bitter liquid that was sprayed to the patient, to the healthcare worker. But for the quantitative test, we can see the numeric, whether we were speaking, whether we nodded or shaking head, because the changing position will change the condition of respirator and must become unfit. Sometimes we can see this when speaking, when nodded head, or when we shaking head, the numeric will be changed here. Patient placement is in urban infection isolation room, negative pressure, completed with HEPA filter, and also exchange per hour 12 times. But if we don't have airborne infection isolation room, place the patient in a single room with good ventilation, closed door, and good airflow. But also, if there is no separate room, please cohort the patient at least 2 meters apart. And limiting the movement of patient from isolation room, use portable examination, ultrasound, and echo.
Yeah, excuse me, Dr. Titi, you have remain 5 minutes.
Okay. The flow of the patient and the flow of the healthcare worker has to be separated. In my isolation room, there is a high pressure or positive pressure in the corridor and negative pressure in the ward. So it will infection in the ward will not go through in the corridor. So the corridor is more safer. If we see the table, we can see that if we see the table, there is a correlation between a higher air change hour with the concentration droplet nuclei in the ward. So the higher of air change per hour will reduce the concentration of droplet nuclei in the ward. We can see this here. If 12 air change per hour, the time needed is 35 minutes. But if we use 15 or 20, the time will reduce more shorter. For healthcare protection, we do this, temperature surveillance, and also we have a policy, healthcare worker who treating COVID-19 not permitted to care other person. Evaluate personnel who are exposed, sick pregnant worker are not allowed to enter isolation room, being prohibited from touching mouth, eye, nose, strict nurse barrier, and minimize number of personnel who get involved in the ICU. This is just sharing. We also use acrylic box and also transparent plastic to protect the process of intubation. The infant cleaning from respiratory care February 20, surfaces of equipment and furniture in patient room harbor pathogenic organism that can be transmitted via skin contact. We know that this virus are able to live for a few days in surface area. chlorine, also hydrogen peroxide, and also ethanol are disinfectant that's sensitive to kill the microorganisms. We had, although we now we deal with COVID-19, but because there's many activities in ICU that cause healthcare associated infection, we cannot forget about bundles. About bundle, occulty bundles, CLEFC bundle to prevent the patient from healthcare associated infection. This is the checklist to know about the compliance, how we do the perform the activities, the medical activities according to the standard of bundles. This is my last slide. The key point is we have to consider designating separate area for patients with COVID-19, encourage hand hygiene after contact with patient, and provide hand hygiene equipment. Clean environment services in patient care area regularly. We recommend 3 times a day, every shift, and when visit the isolation. Ensure that patient care equipment is appropriately clean and disinfected before for each patient. Use standard and droplet precaution when providing close contact, and undertake any aerosol generating procedure associated with an increased COVID-19 transmission in airborne isolation room or a well-ventilated separate room. Ensure that healthcare workers use appropriate PPE and apply bundles to prevent hives. Thank you. Forward to you, Dr. Faisal.
Okay. Thank you very much, Dr. Titi. You have enough time and for a great presentation. I have some note important for your present that infection prevention and control is very important, not only for patient but for healthcare worker too. About early detection and triage, EPA and environmental control is very important. Thanks again, Dr. Titi. And now let's move to the second topic about airway and critical care management for COVID-19 patient ICU, which will be delivered by Dr. Ron D. Hodgson. He's anesthesiology and consultant thoracovascular at National Kidney and Transplant Institute, and he is a board of director Association of Thoracic Anesthesia of Philippines. Dr. Hodgson, you may start your presentation, please.
Hi, good morning.
While you prepare your presentation, I have to announce to all of us in this webinar that our participant today is about 1,000. The register is about 1,700 participants. Okay, please, Dr. Hodgson.
Hi, good morning. First of all, I would like to thank Smiths Medical for this invitation, and it's an honor to be part of this webinar. I'm Dr. Hodgson from National Kidney and Transplant Institute of the Philippines, or NKTI of the Philippines. NKTI is a 400-bed specialty tertiary hospital whose mandate is management of renal diseases. It is located in the heart of Quezon City. This morning I'll be talking about airway management in COVID patient, focusing on safety during intubation. Last March 11, 2020, WHO declared COVID-19 as a pandemic. It is a highly contagious virus that is commonly found in the sputum and upper airways. The reason why the American Society of Anesthesiologists, the Anesthesia Patient Safety Foundation, anesthesia assistant, and nurse anesthetist issued a statement that anesthesia professionals are high risk of exposure and personal protective equipment is mandatory before doing an intubation. Is there a difference between regular airway management compared to COVID-19 airway management? Yes. Why? Because transmission of COVID-19 is primarily droplet spread. However, procedures and events can cause aerosol generation. So, as I said before, it is highly contagious, and healthcare workers treating patients with COVID-19 at increased risk of contracting the illness. So these are the procedures vulnerable to aerosol generation: laryngoscopy, tracheal intubation, bronchoscopy, gastroscopy, front of neck access or airway, including tracheostomy and cricothyrotomy, suctioning, non-invasive ventilation like the CPAP and the BiPAP, and extubation. The main goal of airway management in COVID-19 patient is safety of the staff and also of the patient. In order to maintain safety, we should plan accurately with precise interventions and should be swift because time is of essence. I mentioned earlier that the viral loads of COVID-19 appears in the sputum and upper airways. Staff safety is the highest priority during this pandemic. We have a hierarchy of controls. Of course, the best control is elimination. However, we cannot eliminate this virus right now. And also, we don't want to substitute this virus. Our start of control is actually from engineering. You know, they are responsible for the barriers, all the maintenance of our airflow, as discussed by Dr. Sandori earlier. The administrative control, they are responsible for all the safety guidelines and protocols. Of course, our budget with our personal protective equipment. And again, Dr. Sandori earlier discussed a very good discussion regarding personal protective equipment, which is our last and the least control for this type of infection. And we have a rule in our institution, and I guess all of us are adopting this, that no proper PPE, no intubation. And to protect our equipment and our environment, we should place an HME filter between the mask and the breathing circuit, and a viral filter on the expiratory limb. Patient safety is our highest priority during global COVID-19 pandemic. Guidelines on testing. We should have guidelines on testing before surgery because COVID-infected persons undergoing surgery greatly increase risk of post-operative death. In one of the article, as high as 24% mortality, 30-day mortality rate in patients who will undergo surgery. We have to explain to the patients and relatives regarding limited or no visitors at all. We should also screen the companion during the hospital stay of the patient. Mandatory use of masks and hygiene policy and physical distancing. In managing the airway, we should formulate strategies to keep droplet spread to a minimum and avoid aerosolization as much as possible. So we should optimize the first fast intubation success, less attempt, less exposure. So we should designate most skilled practitioner and assistant. We should pre-oxygenate 3 to 5 minutes, 100% of oxygen. It should be tight sealed. It should be tight sealed. Two-hand technique, VE grip. Positioning is also important. The use of videolaryngoscopy is highly recommended. Either you use dilated EP or Buji first technique. Routine use of vasorelaxant, not only in the operating room, but in the ER and also in the ICU. Deep extubation after the procedure. Use of closed suction system. And if you encounter difficult or challenging airway, call for help early before induction of anesthesia because it takes time for an assistant to come because he needs to don a PPE. These are the examples of scoring and predicting difficult airway. The most important point here is recognition of difficult airway, where preparation is the key. In the ER or ICU, don't wait for the patient to go to cardiac arrest before airway management. We have to remember that this virus is contagious and we need PPE before doing intubation. So how we optimize first pass success rate? First, we do pre-oxygenation. 100%, 3 to 5 minutes, 2-person technique, 2-hand mask ventilation with DE grip. And if you want, as much as possible, don't do bag mask ventilation, but if needed, very minimal bag mask ventilation. Permissive hypercapnia is acceptable. So according to Weingart, if you do pre-oxygenation, apnea time can be extended to up to 8 minutes from 1-2 minutes without pre-oxygenation. I just want to emphasize the use of end-tidal CO2 as a guide in proper pre-oxygenation. Ensure a square end-tidal CO2 waveforms. So it gives you a qualitative and quantitative measurement of how effective is the mask seal during pre-oxygenation. Also, it gives you an expired oxygen measurement. In my personal practice, I will wait until my expired oxygen reaches 70% before giving the propofol. Our colleague in the emergency department had this article last January titled "Should Bed Up, Head Up, Elevated be the new standard position for RSI in the emergency department?" So breaking the table at the hip joint, elevating the head of the bed up to 20 to 30 degrees. And the endpoint is being horizontal alignment between the patient's internal acoustic meatus and the sternal angle. So you have to achieve that air to notch line. So they found out that both video-assisted laryngoscopy and bed-up head elevated direct laryngoscopy provided better visualization of the glottis when compared to supine direct laryngoscopy. And also, it is associated with reduced odds of airway-related complications. The next strategy, which is highly recommended, is the use of video laryngoscopy. So you can see in this table that video laryngoscopy has higher first pass success rate, as high as 93% compared to direct laryngoscopy, which is only around 84%. The next strategy is the use of styleted ET or Buji first technique. Driver et al. Made a randomized clinical trial between styleted ET and the Buji first technique. And the result is very convincing. We have the first attempt success rate in patients with at least one difficult airway as high as 96%, compared to 82% in ET with stylet. And the overall first attempt success rate in all patients is 98%, compared to 87% with the styleted ET. The duration of intubation and incidence of hypoxemia is unremarkable. But the institution where this study was conducted used Buji first technique in the majority of its cases. In our institution, in my own practice, I only use styleted ET, and we find this technique also successful. The next is the use of vasorelaxant. So if we intubate with patients with a COVID-19, we should do the rapid sequence induction with neuromuscular blocking agent, procuronium as high as 1.5 milligrams per kilo, or succinylcholine between 1 to 2 milligrams per kilo. In my personal practice, I use procuronium with the RSI, and if you try to find all the articles, and some of the societies all over the world really recommend rocuronium over succinylcholine when they do RSI technique. So Wilcox et al. Made a study regarding NMB to facilitate intubation in ICU, and they found out that there's an increase of 7% in the first attempt success rate, 7% decrease in hypoxemia, 5% decrease in complications, and significantly improved intubating conditions. And Moser also made a conclusion that using a neuromuscular blocking agent improved first attempt success rate regardless of the choice of induction agent and route of administration. So this is how we intubate our patient in our institution, in patients with COVID-19 or persons under investigation. So these are a sequence of intubation. So after pre-oxygenation, giving drugs and vasorelaxants, we turn off the oxygen during laryngoscopy. So we use video laryngoscopy, and if you have a disposable blade, it is recommended. Together with your assistant, you should observe the EP pass through the cord and note for the black mark just below the vocal cords. That's your first point check. No? Second, next is inflate the endotracheal tube, remove the stylet, clamp the EP by the assistant, attach to the breathing circuit. You should resheath the blade using the outer gloves, unclamp, turn on oxygen, confirm endotracheal tube placement with end-tidal CO2, the second point check, and secure the tube and connections. Clear communication is vital while managing the COVID-19 patient due to the risk of staff contamination. At the same time, PPE may impede clear communication. So we really need to verbalize, we actually verbalize these steps when we do intubation. So with regards to ventilation, it depends on where you are comfortable with. So volume controlled, pressure controlled, or guaranteed volume ventilation. Personally, I use guaranteed volume ventilation because it gives me more stable volume in the face of changing compliance, resistance in changing endotracheal tube leak, and reduction of lung injury. So I always start with a tidal volume of 6 ml per kilo. So it depends on my end-tidal CO2. If it's still high, I adjust my tidal volume, and I usually my target is between 30 to 35. I give
5 minutes remain.
Yeah, I give PIP at 5. If you anticipate delayed extubation, use suction above the cuff, ET, and minimal flow or low flow anesthesia. Personally, 800 ml per kilo. So it provides conservation of heat and humidity of the filters, breathing circuit, and respiratory system. So less atelectasis post-operatively, and also minimize the cost in preventing air pollution. If we have strategy with minimizing the spread of or generation of aerosol during intubation, we should also have strategy to minimize spread during extubation. So we need to use closed suction system, routine reversal agent, which is that's why I like to use rocuronium because it's a specific reversal agent. Perform deep extubation. We clamp the tube before extubation or leave the filter in place, and we place a face mask so that the patient can cough. He can cough in there, or nasal cannula covered with surgical mask, and the oxygen should be below 6 liters. And sometimes we use barrier or the aerosol box during extubation. So as I mentioned earlier, time is of essence. Thus, the standardized guidelines while promoting staff safety shall equate to providing a timely, efficient, and effective airway management. So make it simple, familiar, straightforward solution that can be executed efficiently. Next is simulation. Actually, I'm really a believer of simulation. So this COVID-19 is a new to all of us. due to uncertainties inherent in the new process, regular simulation can address and identify non-adherence to the guidelines. Thus, during urgent and emergent care situations, staff are adequately prepared. So my take-home message are minimize aerosolization by optimizing the first pass success rate for intubation. Staff and patient safety is the foundation in managing patients' airway with COVID-19. Conduct training and simulation to address variances. So with that, I would like to thank you. Keep safe, everyone, and stay healthy. Thank you.
Thank you very much, Dr. Hodgson, for your outstanding presentation today. I have some summary that is very important for airway management for COVID-19, that special condition, because why? Any aerosol, high contagious, and prevention for healthcare worker and around us. So safety is very important. Technically, video learning is going more advantage, and special technique has present by Dr. Hodgson. Ladies and gentlemen, I want to announce that our participant today is around 1,200. So I think it's very big meeting, I think so. And I want to welcome to a new participant who is coming in this